up. So now that they're here, I'm just going to go ahead. And today, I'm going to talk about non-insulinoma pancreatic hyperinsulinemic hypoglycemia. It's a long term, but something that is not very common, but it's very interesting. It was supposed to be a different speaker today, so we made this as a quick arrangement so we could continue our series. So I don't have any conflicts to declare with respect to this particular talk. So I'm going to do is a couple of cases to illustrate the presentations of hypoglycemia in adults. Some describe the genetic and non-genetic causes of hyperinsulinemic hypoglycemia, and go into some of the insights of the mechanisms of insulin secretion that we learned from this particular disorder, and review the evaluation and management of hyperinsulinemic hypoglycemia. So, as you all know, hypoglycemia is a medical emergency, and the main reason it becomes a medical emergency is because of its effect on the central nervous system. Also because severe hypoglycemia will cause autonomic response, which can cause cardiac arrhythmias and sudden cardiac death. So untreated, it can cause permanent neurological damage and also death. It is a common complication of drug treatment for diabetes. So this is the thing that we most commonly see. Severe hypoglycemia reports have ranged from 62 to 320 episodes per 100 patient years in patients with type 2 diabetes, and 3 to 73 episodes per 100 patient years in patients with type 2 diabetes. So much more common in type 1, but also a significant problem in patients with type 2 diabetes. So today we are not going to talk about diabetes-related hypoglycemia. We're going to talk about that's happening in non-diabetic patients. And it is not very common, and it offers a diagnostic challenge. So initially, the description of hypoglycemic disorders was classified as post-absorptive or fasting hypoglycemia, and postprandial or reactive hypoglycemia. So hypoglycemia that occurs within 4 hours after food ingestion. However, over the years, the classification, this particular type of classification is not thought to be all that helpful diagnostically, because sometimes it is actually difficult to figure out whether the patient has fasting or postprandial hypoglycemia. So they have these episodes randomly, and the causes of these could be very similar. So now it is uncommon in people, as I mentioned, in those who have not been treated with drugs for diabetes. So in a large retrospective review of 37,898 non-diabetic, non-critical care hospital admissions, the frequency of hypoglycemic episodes was 36 per 10,000 admissions. So in these patients, it could be a variety of causes, including drugs, alcohol, critical illness, such as hepatic, renal, cardiac failure, or sepsis, and general malnutrition. And most of these patients had multiple possible reasons for hypoglycemia. So this is something that we see, we are consulted in the hospital for us to see these patients for hypoglycemia to evaluate. And this is what we commonly see. Our patients who are very sick, and they probably have hypoglycemia arising from multiple different sources. So, there were only 7 patients in this large series where the hypoglycemia could not be explained by these other comorbidities. And of course, because it is difficult to track these patients and follow them up over a period of time and do a detailed study on them, the etiology of many of these is difficult to ascertain. And there are few data on the frequency of unexplained hypoglycemia in the outpatient setting, because we often get patients who are referred for this, but more often than not, we are not able to demonstrate the presence of hypoglycemia. So that makes it very difficult for us to find the etiology, because we can't even find that there was hypoglycemia. So in 2009, the Endocrine Society put up this task force to look at non-diabetes related, hypoglycemia in adults. And they listed this, and as you can see, they used the classification as those who are ill or medicated individuals. So the most common drugs that cause hypoglycemia are insulin and insulin secretagogues. Then you have alcohol, and then a whole bunch of other medications that can cause hypoglycemia. Then you have critical illness, such as hepatic, renal, and cardiac failure, sepsis, and inanition. And then you have hormone deficiencies like adrenal insufficiency, and in some patients, the severity of the hypoglycemia is due to glucagon deficiency in patients with type 1 diabetes. And then non-islet cell tumors, so mediated through IGF-2 or some other mechanism. The one that we are interested in today that we will be talking about is in seemingly well individuals who have endogenous hyperinsulinemia. The most common thing that we think of when we see endogenous hyperinsulinemia and hypoglycemia is insulinoma. But it could also be functional beta cell disorders, what we call nisidioblastosis, which is much more commonly, or the pediatric endocrinologists are much more familiar with that, because it is seen either transiently or as a chronic problem in children or in neonates. And there are the non-insulinoma pancreatogenous hypoglycemia, post-gastric bypass hypoglycemia, the insulin autoimmune syndromes, and then of course insulin secretagogues, which are not drugs, and then of course lastly accidental or surreptitious or malicious administration of drugs that may cause hyperinsulinism. So I'll present this case. This is a 31-year-old gentleman who I saw for the first time a couple of years ago, and he came because he has a history of a long-standing history of hypoglycemia. Actually, he was diagnosed with seizures when he was 3 months old, and has been known to have hypoglycemia since the age of 18 months. And he had been followed by a pediatric endocrinologist, but he had not seen anyone since he became an adult for several years. He had extensive testing about 15 years before. No specific cause was found. He had imaging studies to rule out insulinoma. He was hyperinsulinemic during the episode, but they couldn't find anything. So, other than the generalized seizure, other than the hypoglycemia, he had generalized seizure disorder and Asperger's syndrome. And he had been on diazoxide, 50 milligrams 3 times daily, and that done fairly well. But since recently he had not seen anyone, he had run out of his prescriptions, and he was getting more often hypoglycemic episodes. And essentially, the physical examination was unremarkable. This is the meal tolerance test that he had, showing that at 4 hours his blood sugar was 60, and you can see that he had hyperinsulinemia at 60 minutes. At 1 hour, his insulin level was 105, then went to 66, 16, and 7. And the C-peptide also peaked at 60 minutes and was still present at 240 minutes. The other things that he had an A1C that was in the normal range. He had an ammonia level which was elevated at 205 micromoles per liter. His rest of the chemistry panel, including liver function tests, were all normal. And what was interesting was the family history of hypoglycemia. It means his daughter had hypoglycemic episodes. He had been divorced, so he could not provide much of the history because he only knew that this was happening to his daughter, but he was not the one who was going with her to his pediatrician. But there was something that they told me which helped me make the diagnosis. I don't know, our fellows are here, and I can ask them, 2 of our fellows, and I can ask them if they know what the diagnosis was. So he has 2 things. One is that he's hypoglycemic and hyperinsulinemic, and he also has a high ammonia level. Right. So I'll come to that when I'll present further. So this is a condition of hyperinsulinemic hyperammonemia with hypoglycemia, and it is due to a mutation in the glutamic acid dehydrogenase 1 gene that causes both of these problems. So, I'll discuss the hyperinsulinemic hypoglycemia and how, what are the different abnormalities that we find, and also in this particular condition, what happens. So, hyperinsulinemic hypoglycemia is characterized biochemically by an unregulated secretion of insulin from the pancreatic beta cells, even in the presence of low blood glucose. So that's the main thing, that when the blood glucose is low, they have high insulin levels. Obviously, under normal circumstances, the beta cells synthesize and store and secrete insulin in a very controlled manner, so the blood sugar is ranged between 3.5 and 5.5 millimoles per liter. The genetic mechanisms that lead to hyperinsulinemic hypoglycemia are actually defects in the pathways that regulate insulin secretion from the pancreatic beta cell. There are some other mechanisms that are also there, which I will address, but this is the predominant mechanism by which you get hyperinsulinemic hypoglycemia. So these genetic defects perturb the normal secretion of insulin. The most severe one of these occur in the neonatal period, and our pediatric endocrinologists would be very familiar with them. However, it can also present in infancy, childhood, or in adults, and many of them could be, especially in the milder forms, they may not be diagnosed when they're young and may present in adulthood, or they might have been diagnosed when they were children, but they eventually present when they are older. So we also see them in our clinics. So this is the list of the causes of hyperinsulinemic hypoglycemia. So you can see that there are genetic causes, and of these, the first 2, the ABCA8 and KCNJ11, are what we call channelopathies. That is, they are mutations in the potassium channel that regulates insulin secretion, and the remaining are kind of metabolic pathways that lead to an increased secretion of insulin due to an increased generation of ATP. Then there are some secondary causes of hyperinsulinemic hypoglycemia. As you can see, many of them are transient, such as maternal diabetes, intrauterine growth destruction, perinatal asphyxia. Then you have some metabolic causes, and we'll go through some of them. And then you have the miscellaneous causes of, then you have the syndromic causes like the Beckwith-Friedman syndrome, trisomy 13, leprechaunism or insulin resistance syndrome, Turner mosaics, Soto syndrome. So there are some genetic syndromes in which hyperinsulinemia is a feature, and to varying degrees develop hypoglycemia. And then you have the miscellaneous causes, postprandial hypoglycemia due to a receptor mutation in the insulin gene, the insulin receptor, dumping syndrome, insulin autoimmune syndrome, bariatric surgery, and of course you have insulinoma, and non-islet cell tumors causing hypoglycemia, factitious hypoglycemia, and drug induced. So this is the kind of a comprehensive list of hyperinsulinemic hypoglycemia. So this is just to point out what the basic mechanism of insulin secretion is. So as you can see here, the glucose is transported into the beta cell through the glucose transporter GLUT2, and the glucose is then metabolized and then generates ATP, which is then acts on the ATP-sensitive potassium channels, which by closing the channel causes depolarization and the entry of calcium into the cytosol, and that causes insulin secretion. Insulin is stored in granules and it is secreted. So the triggering mechanism for insulin secretion is this process. The ATP-sensitive potassium channel is the main pathway, the main trigger for insulin secretion. The closure of the ATP-sensitive potassium channel and depolarization of the cell causing calcium entry and insulin secretion. There are other things that can affect ATP, particularly, here it could be pyruvate or lactate, which can, increase ATP that enters the cell through this transport protein. Some of the amino acids, particularly glutamate, through glutamate dehydrogenase, alpha-ketoglutarate, and again, increase in ATP, also have this pathway by which it is insulin is secreted. So the ATP-sensitive potassium channel, as we call them, has got, this is a what we refer to as a sulfonylurea receptor. So this has both the transmembrane region and the cytosolic portion, and this is where you have the nucleotide binding sites. So this is where ATP binds, and this is the channel protein, the potassium channel protein. So the full channel consists of 4 of these. So when you have the ATP bind to this portion of the transmembrane domain of the receptor, that is when the ATP channel will close, and that will cause depolarization of the cell, because the potassium will not be entering, and then that'll depolarize and cause entry of calcium. So this is the comprehensive kind of where the different mutations and how they can cause problems with the secretion of insulin. So you can have defects in glucokinase or hexokinase genes, which can cause an increase in the generation of ATP, which can then lead to, so mutations here can cause either diabetes or hypoglycemia. So it depends on what type of mutation you have. As I mentioned, I talked about the pyruvate, and this is an interesting phenomenon because this protein, the MCT1 or the monocarboxylate transporter 1, this is involved in transporting pyruvate into the cell, and then it can go through the cycle here and generate ATP. And this actually happens when you exercise. So in some patients, there is a mutation in this gene that will overtransport the pyruvate. So whenever these individuals exercise, they become hypoglycemic because there is generation of pyruvate when you exercise, and then pyruvate goes into the beta cells and stimulates the ATP and the generation of ATP, which then you will secrete insulin. So it's not a glucose-dependent secretion of insulin, but it's dependent on pyruvate. So Then, of course, you have the sulfonylurea receptor, which I said is the triggering mechanism for insulin secretion. Here you have glyburide, which will inhibit it, which means that it will increase secretion of insulin, whereas diazoxide does the opposite, and therefore will decrease insulin secretion. And that's one of the reasons why we use diazoxide as a drug for hyperinsulinemic hypoglycemia or other types of hyperinsulinemic states, because if you use diazoxide, it will decrease insulin secretion and it will help. However, one thing is if you actually have a mutation in the receptor itself, the diazoxide may not work because it needs this receptor to be intact for it to work. So, in the mutations of ABCA8 or the KCGN11, diazoxide is not very effective because it works on this protein itself, and that is defective, and it won't work. Then you have, as I talked to you about, the GDH or glutamate dehydrogenase 1 pathway, and in this case, the thing that primarily triggers it is the leucine amino acid. So it is not a glucose-stimulated thing. In fact, these patients will become hypoglycemic when they actually eat more protein, particularly anything that contains leucine will make them hypoglycemic more than taking glucose. So, and also here, the mechanisms through which the GLP-1 receptor, GLP-1 and exendins work is also through its action on these pathways. So, currently, there are 9 or probably now 11 known genes, the mutations of which are associated with familial hyperinsulinism. These are the ABCA8, which includes the sulfonylurea receptor 1, KCGN11, which encoding a subunit of the potassium channel, which is KIR 6.2, GCK encoding glucokinase, GLUD1 encoding glutamate dehydrogenase. Then you have HADH1, and then SLC16A1 is the one that codes for this particular protein, and then these two hepatocyte nuclear factors 4 and 1, and also the UCP2 encoding uncoupling protein 2, which is a mitochondrial protein. And again, the mechanism by which there's an overexpression of this can generate more ATP within the islets and cause hypoglycemia. So the hyperinsulinemic hypoglycemia and hyperammonia syndrome, as I mentioned, the major clinical feature of these children is recurrent episodes of symptomatic hypoglycemia. They may occur in the fasting state, but are usually seen in, it also occurs in the postprandial state, especially by protein feeding, as I said. It is not usually very severe. So one of the confusions here is that this disorder also has seizure disorder as one of its components. So a lot of the times these patients become hypoglycemic. They also have seizures. So people confuse that these seizures are due to the hypoglycemia and therefore they are very severe, but it is not. They have a seizure disorder due to a different mechanism by which they can have seizures without having even with hypoglycemia. So the majority of these cases are sporadic, and there are also familial patterns that are seen. And the plasma concentrations of ammonia are elevated in children and also in adults. And as I showed you, they're about 2 to 5 times the upper limit of normal. And what is interesting about this particular condition is that even though they have very high ammonia levels, like my patient had an ammonia level that was 270 or so, he was absolutely having no symptoms of hepatic encephalopathy or any mental status changes. And that is because there is a pathway by which in the brain, the same enzyme can overcome this problem and they don't develop any symptoms of hyperammonemia. So they don't show the lethargy, headaches, or any of these problems. So as I mentioned here, it's the leucine that stimulates the production, the secretion of insulin. And in the liver, the elevated activity of glutamate dehydrogenase, conversion of glutamate to alpha-ketoglutarate and ammonia. And then, of course, it can go through the urea cycle pathway to be cleared. However, what happens is that there is a deficiency of this enzyme of N-acetyl glutamate, because all of this is going here, and now that cannot be converted to urea because you don't have this, the N-acetyl glutamate. So these patients have both an increased generation of ammonia and a decreased ability to clear that. And that's the reason why they become hyperammonemic. So they have high levels of insulin, high levels of ammonia, and So this is a summary of the several of the mutated genes that cause familial hyperinsulinemia syndromes. Many of them have their origins in childhood, and they are eventually seen as adults by us. These are the most severe forms of hyperinsulinemic hypoglycemia, are the ABCC8 and the KCNG11, and they don't respond well to diazoxide. So that's one of the problems with them. And there are two different forms of this. One is a more diffuse form of this hyperinsulinemic hypoglycemia, which affects the entire pancreas. So all the islets are affected. But there's also a focal form where this is limited to certain parts of the pancreas. In those patients, you can actually surgically partially remove the pancreas and they will resolve. In some cases, the only treatment for them is a total is a pancreatectomy. They'll become diabetic, but if they're having severe hypoglycemic episodes, that's the only option that you have. Then you have the glucokinase mutation. It is involved in glucose metabolism. It's an activating mutation, the normal birth, and the response to diazoxide is variable depending on a specific mutation that they have. Then you have the SHAD mutation, the mutation of the gene making the SHAD protein. This is involved in fatty acid oxidation, and they do respond to diazoxide. So also there's a partial response for the patients who have the MCT1, which I said is an exercise-induced problem that you can get. There's a partial response to diazoxide. You have the two HNFs. Then, of course, I talked to you about the GLUT1. UCP2 mutation, it involves the uncoupling protein. There's a dominant loss of function. And this also, because it is the generation of ATP, the diazoxide can block the activity of these potassium channels. So it might work. There are also some inborn errors of metabolism that are inherited that can cause some of these problems. But they constitute a very small number of patients. And you can see from the journal from which I got this, which is the Orphanet Journal of Rare Diseases. So it is very rare to find inborn errors of metabolism that cause hypoglycemia. But it can be a presenting feature of some of the hypoglycemic disorders. And here you have, again, you can divide them into fasting and postprandial and exercise-induced. And these are disorders of glycogenolysis, fatty acid oxidation, or gluconeogenesis. These are occurring in the fasting state. So these, you have to distinguish them from an insulinoma. So when you do a fasting test, what you will find is, they can become hypoglycemic. Then you have the reactive hypoglycemia. You have inherited fructose intolerance. We'll talk a bit about the non-insulinoma pancreatogenic hypoglycemia syndromes. And then, of course, this one we briefly talked about. So when do you consider these? Glycogenolysis disorders of fasting, so are the fatty acid oxidation disorders, and the gluconeogenesis disorders are usually due to prolonged fasting. Because as you know, when you fast, you can, in the short term, you can maintain your blood sugar by glycogenolysis. So whereas, if you, with prolonged fasting, you need gluconeogenesis, there will be ketotic, there may have some lactic acidosis, high aniline levels during fasting. Those are the different things that might give us some clues to this diagnosis. Now, I talked about this particular thing, which I will talk to you a bit more about the other types of non-insulinoma postprandial hypoglycemia syndromes. For the diagnosis of these particular conditions, most of the times, we look for insulinoma. If it is not an insulinoma, you conduct, further testing, looking for different amino acids, looking for the presence of hepatomegaly or ketones. And then, of course, you can do, if you think there's inherited disorders of fructose intolerance, you can do molecular diagnosis. You can do a mixed meal tolerance test, which will tell us, and I'll come to that when we talk about the postprandial hypoglycemic disorders. So one of the things that we have learned from these syndromes of hyperinsulinemic hypoglycemia is about the mechanism by which insulin is secreted. We know what the ATP channels that are the triggering pathway to insulin secretion and can cause severe hypoglycemia. The exercise-induced hyperinsulinemia illustrate that this is what we call a disallowing cell expression of some of the common gene paths permit the unregulated secretion of insulin. And we've also learned about the key role of glutamic acid glutamate dehydrogenase and its inhibition by GTP in controlling amino acid stimulated insulin secretion and CNS function. Because as I said, it is this pathway that actually prevents the changes in the brain metabolism in this condition where they're not getting confused and having symptoms of hyperammonemia. So I'll present another case, which is something which we often see. It's a 24-year-old lady who was seen for the evaluation of hypoglycemia. She said she was having episodes of hypoglycemia since she was in high school. She reported the symptoms around 10 or 11 a.m. while in high school and had to eat every 2 hours or so. She reported that her symptoms improved about 10 to 15 minutes after eating some carbohydrate, and they started to be more prominent about 5 years ago. She had, however, not reported any episode for which she had to go to the ER or need a hospitalization for hypoglycemia. She had a 72-hour fast that did not reveal any abnormalities. She did not become hypoglycemic. She had an oral glucose tolerance test that was performed here by an endocrinologist elsewhere, but in Louisville. And it showed a peak glucose of 168 at 30 minutes, and at 2 hours it was 67. Corresponding insulin levels were 3.9, 272, and 44.6. Now, she had normal insulin resistance calculations, insulinogenic index, and disposition, and they were all normal if you looked at it. Now, in 2019, she went to the Mayo Clinic where they performed a mixed meal tolerance test, and the glucose did not show much of there was no hypoglycemia that was demonstrated. Blood sugar ranged from 92 to 81 milligrams. Insulin was 4.7 to 46.2. So the question was about, does this patient have postprandial hypoglycemia? She had these symptoms, and she did get the label of reactive hypoglycemia, and that's one of the questions that has always been there. I mean, is this true reactive hypoglycemia, or what is the actual diagnosis? And this is an editorial. As you can see, the title itself said non-editorial non-hypoglycemia. And this is something that I remember from my days as a fellow in endocrinology way back in India in the early 1980s. And at that time, I had read this article, and you remember this because it's a New England Journal article which had a funny title. And also, it was by George Cahill, who was the research director of the Joslin Center from 1962 to 1978, and Stuart Soldner, who was one of the topmost diabetologists at the Joslin Center, involved in all the type 1 diabetes studies, including the DCCT design and all that. And the basic point that they were making was that this entity of hypoglycemia after a meal is incorrect. That the symptoms more often than not are not related to hypoglycemia. So that patients will complain of symptoms of hypoglycemia, that they are a bit non-specific. A lot of the times they are having some bloating, they feel sweaty, they feel uncomfortable, and more often than not, there is no simultaneous recording of a blood sugar that will demonstrate this. So they had said that true hypoglycemia following a meal is very rare, except, of course, in patients who have had gastric bypass or other types of gastric surgery. So, but this has been studied, and the problem is that the criteria that have been used for defining this particular problem are highly variable, so it's not well defined. So the one thing that I again want to point out is also that it is not a good idea to do a glucose tolerance test to diagnose this problem, because 30% of individuals, especially young women, will show an abnormal, a low glucose at the 4th or 5th hour after a glucose load. On the other hand, if you do a mixed meal tolerance test, then the rates are going to be much lower. So always do a mixed meal tolerance test if you suspect it. The mixed meal, typically you can use, here, for example, for the ones that we're using for our islet transplant patients is to use Boost, or you can use Sustacal, or one of these protein shakes which have a significant amount of carbohydrate in them. And then you can do the test as is outlined here. So a glucose tolerance test is not a good test. Now, this is how you interpret the set of results that you will get from these. So this one here basically will tell you what is going on. This is from the when you do a fasting, or whenever you have a low blood sugar. That means you want your blood sugar to be less than 55. And then you look at what the insulin level is at that time. And that'll tell you whether it is normal, whether it is, hyperinsulinemic hypoglycemia or not, okay? Of course, you distinguish endogenous and exogenous based on whether the C-peptide at the same time is low or not. So if the insulin is high and C-peptide is low, you say it is exogenous, and if both are elevated, it's endogenous hyperinsulinemia. Then beta-hydroxybutyrate helps us because in all conditions in which there is insulin excess, there is a suppression of beta-hydroxybutyrate. So other conditions that non-insulin mediated hypoglycemia will have beta-hydroxybutyrate. So this one here is about the glucose response after you give glucagon. So if the patient becomes hypoglycemic and we give them a 1 milligram injection of glucagon and check their blood sugar. Now the thing is that in conditions where there is non-insulin mediated hypoglycemia, there is a depletion of the glucose stores in the liver. Whereas when you have a lot of insulin, and insulin is the cause of the hypoglycemia, the insulin is increasing glycogen storage in the liver, so they have more stores of glycogen, and when you give them glucagon, it releases glucose. So in conditions where you have non-insulin mediated hypoglycemia, you will have less of a glucose response, whereas insulin mediated hypoglycemia, you have more of a insulin glucose response. And then, of course, you have the measurement of the medications and then antibodies to insulin. So this is a comprehensive list on how you interpret the results of insulin and glucose, whether you're doing it in the fasting state or in a stimulated state. When you look at the blood sugar and the insulin levels, having this additional information will help you. So as I said, spontaneous hyperinsulinemic hypoglycemia in the postprandial state, or what is called a non-insulinoma pancreatogenous hypoglycemia, is uncommon, without a prior history of gastrointestinal surgery. So this study from the Mayo Clinic, they actually reported, 5 adults with neuroglycopenic episodes of hyperinsulinemic hypoglycemia within 4 hours of meal ingestion and negative 72-hour fasts. Okay, each of them had abdominal ultrasound. They had CT scan, a celiac axis angiography, and they all showed selective arterial calcium stimulation. So we don't do that anymore. In the past, they did do where you catheterized the pancreatic artery and injected calcium, and then you measured the insulin secretion. As an invasive procedure, very difficult to do, but now with improved imaging techniques, we don't do that to diagnose insulinoma. At pancreatic exploration, they did not find insulinoma, and many of them, had partial or total pancreatectomy. So this is these are the 5 patients, and you can see, that they all had low blood sugar, they all had high insulin levels at the time that they were hypoglycemic, high C-peptide, negative antibodies, and negative drugs. So the resected pancreatic showed islet hypertrophy and acidoplastosis, but no insulinoma. And they also looked for some of the genes that had at that point been identified, particularly KIR62 and the sulfonyl receptor 1 genes. And they did find some mutations, but they did not find anything that would likely be contributing to the hyperinsulinism. So this is the histology from this. And what you can see here, this is the normal islet, and this is the islet from patient who had hyperinsulinemic hypoglycemia, postprandial hypoglycemia. So they had nuclear polymorphism, and the islet was about 3 times larger than the normal islet. And you can also see one other interesting feature, which is that this is the pancreatic duct, and you can see this is staining positive for insulin. So there's also, suggesting the possibility that, as you know, that islet neogenesis can occur from pancreatic ductal cells, so that they have increased ductal differentiation. So there are some mutations that they did find in these patients, but they were not disease-causing mutations from their analysis of the thing. But the more common type of hyperinsulinemic hypoglycemia that we see is bariatric surgery and related hypoglycemia. So patients who have Roux-en-Y gastric bypass surgery, they have a lot of improvement in glucose metabolism, and of course, they can also have hypoglycemia. So it is commonly seen, but it can also be seen with other types of upper GI surgery. I had another case which I thought I would present, but unfortunately I couldn't get the CGM pictures of that downloaded, so I didn't present. This was a young lady who had initially had Nissen fundoplication, then more esophageal surgery, gastrectomy, eventually had chronic pancreatitis and even islet transplant, and she had a very typical hypoglycemia like what you see after gastric bypass surgery. So the precise incidence is kind of unknown because, as I said, there are different diagnostic criteria, whether they are reported on symptoms or not. But severe postprandial or bariatric surgery related hypoglycemia requiring hospitalization is very rare. It's less than 1%. A lot of the people do have symptoms, but minor types can occur from 10 to 30% of individuals, both after Roux-en-Y gastric bypass surgery and vertical sleeve gastrectomy. So there is no published data on the prevalence of this after upper GI surgery, but there are case reports that tell us that this thing can happen. So the mechanism that is postulated is in rapid delivery of nutrients to the gut, then early high glucose peak, increase in postprandial GLP-1 and other gastrointestinal hormones such as GIP and PYY. There is an increase in beta cell sensitivity to glucose, increased postprandial insulin secretion, and also suppression of insulin secretion and insulin clearance. Decrease in cortisol and glucagon have been reported in some of these patients, causing postprandial hypoglycemia. There are other factors such as insulin-independent glucose uptake, differences in the microbiome, bile acid changes, decreased hepatic glucose production. Sometimes it is due to nutritional factors related to the weight loss, deficiency of certain types of amino acids, and also genetic predisposition. So there are multiple factors that lead to this particular problem. It is much more common in females and younger age, but the data one is a bit more because it's skewed because most of the bariatric surgery patients tend to be female because they're the ones having surgery more than males. So, some of them have had a history of hypoglycemia prior to surgery. The greater excess weight loss, the more weight loss they've had, the more likely that they're going to have this particular problem. Usually it starts about 1 to 3 years after surgery. They have the typical symptoms, but the thing is that a lot of the times it is difficult to figure it out because they can complain of morning headaches, bizarre dreams, mood swings, all of these kinds which they attribute to their hypoglycemia. Typically, these occur 1 or more hours after a meal, and most commonly after ingesting a rapidly absorbed high glycemic index carbohydrates. Some can also attribute it to activity, stress, and then of course the multiple episodes can occur in a single day. So that is something that one has to be careful about because they get hypoglycemic, they drink something, they feel better, then again they become hypoglycemic. It has some features of the dumping syndrome in the sense that the symptoms of the dumping syndrome are much more rapid. They occur, within 10 to 30 minutes postprandially. Some people call this the late dumping syndrome, because this occurs 1 to 3 hours after the meal. Now, the key components of managing this in terms of diet is choosing low glycemic index carbohydrates and avoiding high glycemic index carbohydrates, controlling the portions at 20 grams to 30 grams per meal and 10 to 15 grams for snacks. Include heart-healthy fats, then space the meals and snacks 3 to 4 hours apart. Avoid liquids with meals, and also for 30 minutes after meals, avoid caffeine and alcohol, and then adequate vitamin and mineral replacement. The pharmacologic therapy of these, has been acrobose. It can slow the absorption of carbohydrates by preventing the breakdown of complex carbohydrates. Diazoxide, octreotide. Then we have, in the more severe cases, we've used octreotide and sandostatin LAR. Pasireotide can also work. It's more expensive. Again, it has been used, and it is given once every 4 weeks, so it's more convenient and has been used. Some people have also used liraglutide and calcium channel blockers that have been found to be helpful, particularly for symptomatic relief, but there are other symptoms related to it. There's a lot of psychosocial support that is needed in the management of patients with postprandial hypoglycemia. This refers to those with bariatric surgery, but even for those who complain of these symptoms, who have not had surgery but have some of the symptoms and some of the clinical features that look like the post-bariatric surgery syndrome, where we are unable to establish a true hypoglycemia, it would be helpful to try different diets and they are afraid to try things because of this, and then they're afraid of weight gain if they eat more. If you tell them to eat more frequently, there are some physiological factors, and they may not like the foods. Then you can look at using CGMs, but people are sometimes very many of you have worn the CGM. You know that it will keep alarming every time it goes below a certain level. Then there are also certain socio-cultural factors which impact how we manage these patients. So these patients who have reactive hypoglycemia actually are quite difficult to manage in terms of not just that there are no good medications, but they also need a lot more psychological support to manage their symptoms. This is a new drug. As I said, one of the hypotheses is that GLP-1 will, the release of GLP-1 is what causes the increased secretion of insulin and hypoglycemia. So this study used a drug, avexitide, for the treatment of post-bariatric hypoglycemia. And in this particular study, they were looking at glucose and other insulin peak during a mixed meal tolerance test and hypoglycemic episodes by self-monitoring and CGM, blinded CGM. So compared to placebo, avexitide 30 milligrams and 60 milligrams once a day raised the glucose and other by 21% and 26%, lowered the insulin peak by 23% and 21%, and corresponding to 50% and 75% fewer participants requiring rescue during the mixed meal tolerance test. So there's a significant reduction in the rates of levels 1 to 3 hypoglycemia. So, as less than 70, less than 54, and severe events. So there was a benefit of using avexitide for 28 days. So it was well tolerated. So this is one of the drugs, is a GLP-1 antagonist that has been developed. It's still not available. This was published just in February of this year, and this is published online, so it's not in print yet. So the next set of disorders when you get hyperinsulinemic hypoglycemia is the insulin autoimmune syndrome. This was described about 55 years ago. This article from was 50 years after the initial discovery. It is also called Hirata's disease in Japan. It's a rare condition. There are hypoglycemic episodes due to high titers of insulin autoantibodies. And it is usually a form of immune-mediated hypoglycemia triggered by a medication or a viral infection. The exact pathogenesis is somewhat unclear, but there's a double-phase mechanism. So the autoantibodies prevent insulin to bind to its receptor in the postprandial phase, possibly resulting in mild hyperglycemia. Thereafter, insulin is released from the complexes irrespective of blood glucose, thus inducing hypoglycemia. So the diagnosis is difficult, requiring careful workup. The gold standard is the demonstration of insulin autoantibodies in a blood sample. Because these are self-remitting, it's mostly supportive care. Now, usually the insulin autoantibodies will, over time, they will go away. So occasionally you can use some pharmacologic therapies like we use for other types of hypoglycemia. There are, these multiple reports that have been there, epidemiologic studies. So you can see that, there's anywhere from, it depends on the referral centers. So of all the patients that were referred for unexplained hypoglycemia, 41 out of 350 patients here, 9 cases per year, 197 over a 22-year period. And you can see that a lot of these are from Japan that have been reported. So there are a whole bunch of drugs that are known to trigger this autoimmune response, and these include antithyroid medications and carbimazole. And then of course some of the supplements such as alpha lipoic acid, glutathione, Supplements are very popular among people who are very much interested in healthy lifestyle. Then the antihypertensives, antiplatelet drugs, or antidiabetic drugs, even steroids can trigger insulin autoimmune response. So there are multiple medications that can cause this, generate the insulin autoimmune response. Unfortunately, most of these are self-limiting, and over time, the antibody response will go away and they will be doing okay. So this is just the general workup for the insulin autoimmune syndrome, which is very similar to the thing that I. So this is just to show you what might happen, when you have the plasma glucose concentrations will initially go up, and it's the main thing here is that you have an erratic response. I mean, it goes up here high, and then suddenly when the insulin concentrations, they kind of stay up here, and it drops dramatically over time. The free insulin concentration is here. Now the free insulin here is low. The total insulin concentration is high because it's all bound to the protein. And then at this point, you're having high insulin concentrations, and the blood sugar is dropping very low. And then, of course, here you're having your free insulin concentration go up. That is when it drops. So the insulin is bound. It's not acting, and then the blood sugar goes up. And then at this point, when you have more free insulin, it'll drop suddenly, and then you go into this hypoglycemic episodes. That is the mechanism by which the insulin autoimmune syndrome causes episodes of hypoglycemia. So, as I mentioned, I just wanted to bring out some of the important things to know about hyperinsulinemic hypoglycemia. My last slide, for whatever reason, got eliminated, and I couldn't fix it. That would summarize all of these findings, all the things that I said, to give you some concluding remarks. But I will stop here, and if you have any questions, we'll be glad to answer. This is the code for today for the CME, for those who want to get the CME credit.
Nice.
Thank you.
So,
yeah.
Can I start question?
Yeah.
So, one of the questions I had was, what is the frequency or the prevalence of the hyperammonemia?
So it is the second most common set of disorders among hyperinsulinemic hypoglycemia. The most common are the ABCC8 and the JCN11. Those are the ones that are the most common. This is the second most common. I think it's around 1 in 50,000, or it's very rare. It's a rare.
Extremely rare, right?
Correct.
Because the data that you showed, many of it looks like many of the patients in the clinic, they get brain fog, of course, no seizures, but kind of almost like the reactive hypoglycemia, or similar, or perhaps So I was just wondering, are we missing any of them? Number one. Number two is seizure like a component, like is it part of it, or may or may not be there?
Well, most of them have seizure disorder, and it is related to the pathway by which the glutamate dehydrogenase 1 is in the brain, that it can cause seizures, but not necessarily, it is not usually not due to hypoglycemia.
It's in the family, though, like your patient, the daughter has it,
correct.
She has it. We don't know if it's other, like parents or anyone else.
Nobody else that we know. I mean, even he, because insurance was not allowing us to do the sequencing, but his daughter did have it, and we know that she has GLUD1 mutation.
Right.
That is something that we know for her, So we assume that's what he has also.
There are other questions there.
Okay. So,
Hello.
hey, yeah.
Hi, Dr. Mokshagundam. Thank you. Very comprehensive. I'm sorry, I didn't know. Was I talking over somebody?
No, you're fine.
Okay. This is Swapna. So,
Yeah.
great talk, very comprehensive. I've always wondered about this one thing. I know you mentioned that it's not always the glucose that might be causing the fog and the other symptoms, but often in some of these patients where the so-called reactive hypoglycemia, or even in normal patients with no bariatric surgery, they might have very high insulin levels with a fairly okay glucose. Do you feel that the insulin levels contribute to any of these symptoms, these vague symptoms that these patients complain about? So if they have like 150 or whatever insulin, or even higher, some of my patients, they seem like, is there any connection between the insulin levels by itself?
I don't think so. I mean, the question then comes up is whenever you see an insulin level that is high, obviously, and if the blood sugar is normal, you're looking at insulin resistance. And sure, insulin resistance has been linked to some of the, fogginess and things like that. So whether that is the problem or whether it is the insulin itself that is causing the problem, it's very difficult to dissect it out, and find out which of these is causing the problem. So and because these are not reproducible, that is the whole problem that in trying to control it and see if the symptoms go away or how it will respond. So
just clinically, it does seem that as they improve their diet and the insulin resistance gets better, this fogginess does get better. So
correct.
I wonder what role.
So the question is that the insulin resistance got better, or is it because the insulin was lower? Yeah.
Right, but it's kind of all interconnected. I mean, the insulin
correct.
resistance getting better means the insulin levels are better. So it's tricky.
Yeah.
So, okay, thank you.
Okay, Dr. Bays?
Yes, well, I want to echo what was just said. It's about the most comprehensive discussion of hypoglycemia I think I've ever seen. And I must say, I think maybe some of the people know, I've done clinical research for 30 years, but I must say I don't remember the hypoglycemia hyperammonia syndrome. That one somehow escaped me. A couple of comments. First off, some of your folks might be interested that when you talk about diazoxide, about 10 years ago, we published some data in Journal American College of Cardiology. We were trying to use diazoxide to lower triglyceride levels. And I found that to be very interesting. And the program development really didn't proceed, as you might expect, because these people developed hyperglycemia. Yeah. So it was a very curious program, but we had a controlled release formulation. We did a clinical trial on it. But I guess my only major comment was, back in the day, I used to see a lot of the patients with the signs and symptoms that you talked about, with the after meal lightheadedness and feeling bad and all those types of things. And what I found on numerous occasions was that it was not low blood sugar, but low blood pressure. And these patients, and they would typically be younger women who were thinner, athletic, and some of them were athletes, and they would pass out in the gym and such. And then somebody would go check a blood sugar because they had a glucometer with them. And when they did, the blood sugar was low, because whenever you have somebody that's hypotensive, their blood sugar is going to be low. And so then they would feed them a bunch of sugar and everything. So I guess what I would say for maybe folks in training or whatever, if you have a patient that comes in, particularly, again, younger women, particularly if they have history of migraine headaches or family history of migraine headaches, some sort of vascular thing, don't just check their blood sugar, check their blood pressure, because you could make a diagnosis in the office which hadn't been made for like 5 years by countless tests and mixed meal challenges and all that kind of stuff. You can make the diagnosis right there in the office without having to spend anything but your time.
Yeah, thanks. Yeah, that's been the thing that, in fact, that editorial, the reason why I remember that was also, apart from the title saying non-editorial on non-hypoglycemia, it actually was referring to a paper that was published in the same issue of the journal, where they studied it. They went back and looked at the diagnosis of reactive hypoglycemia. And this was in the 1940s that these guys went back and looked at the records, and they found that these reports from London clustered around when there were these bombing blitzes that was happening. And they said that a lot of these symptoms were related to anxiety at the bombing. And one way to keep the people calm is to tell them, no, it's because of blood sugar. Just eat something, you'll be fine. So it was a way to calm them down, that they made this as a way to get out of instead of telling them that you're just anxious. So that article was talking about how many of these symptoms are not related to a low blood sugar, and it's often anxiety or some other things. So Girish had the question about single nucleotide polymorphisms. There are multiple. Most of them are single nucleotide polymorphisms, and but there are many of them, that have been reported. If you go into the details of it, they have mapped those out. But because there are only a limited number of patients, we can screen for them. But particularly the ones that are most common, like the glucokinase, so the GLUT1, the ABCC8 and JCN11, those things we can get it done. For others, you probably have to go to a research lab to get the full detailed ones done. If there are no other questions, we'll see you again next week. Okay.